Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Glad to be here for this one.
Yeah, so picture this. You're standing in the trauma bay, the doors fly open, right? EMS rolls in a 25-year-old male, gunshot wound to the left chest.
A nightmare scenario.
Completely. The monitor is just screaming. The pressure is tanking. We're talking 60 over palpable, then 40, then nothing. Agonal breath.
And you throw the probe on.
Right. You do the fast exam and you see this massive dark stripe of fluid around the beating heart. You have, fractions of a second to make a decision that will irrevocably alter this patient's physiologic trajectory.
Exactly. And today, we aren't just reviewing the basic anatomy of, how to hold a scalpel or where to make a cut.
No. Sure. For you, the U.S.-trained trauma or surgical critical care surgeon, the decision to perform an emergency department thoracotomy, to literally crack a chest right there in the resuscitation bay, that's the ultimate line in the sand between life and death.
It really is.
So we are undertaking this massive, exhaustive deep dive into the foundational definitive text on the EDT, authored by Dr. Juan A. Asensio and his colleagues. We're looking at the brutal, unvarnished physiologic cost of this procedure.
And that is exactly the level we need to be operating on today. We have to elevate this conversation far beyond mere anatomic access.
Right.
Because when you open a chest in the ED, you are not just performing a surgical intervention. You're attempting to completely rewrite a collapsing hemodynamic reality.
A total system override.
Precisely. The text we're analyzing is a masterclass in the exact physiologic management of a patient in extremis. It really forces us to critically evaluate that absolute boundary between salvageability and, well, clinical futility.
Which is a tough pill to swallow sometimes.
Very tough. But today, we're going to explore the very real and frequently lethal pitfalls of damage control surgery. We're going to dissect the precise methodologies and the glaring limitations of the literature that dictates your trauma protocols. We'll break down the rigorous, uncompromising patient selection criteria that absolutely must govern your hands.
It's so much more than just the mechanics of the cut.
Yeah, it's about understanding the profound multi-system costs of your interventions, like the aortic cross-clamp. And it's about mastering complex, high-risk adjuncts, things like total inflow occlusion and the intricacies of advanced cardiography under fire.
Okay, let's unpack this. Because before we can even touch the modern statistical outcomes, the p-values or the American College of Surgeons guidelines, we have to build the foundation.
We have to know where we came from.
Exactly. We need to understand what this operation is actually attempting to achieve on a cellular and hemodynamic level when that patient is bleeding out on your stretcher.
Right.
But to appreciate the physiology, you really have to appreciate the sheer audacity of the history here. The timeline in the text is wild. It takes us all the way back to 1874.
1874.
Yeah. Think about the state of medicine in 1874. No modern anesthesia, no antibiotics, no advanced monitors. And yet, a surgeon named Schiff becomes the first to promote the concept of open cardiac massage.
Which is just stacked.
He essentially says, the heart stopped, let's just open the chest and squeeze it ourselves.
It was revolutionary, and frankly, it was deeply controversial at the time. You have to remember, for centuries, the heart was considered surgically untouchable.
Right, like a sacred off-limits zone.
Exactly. The prevailing wisdom was that any wound to the heart was universally fatal, and attempting to suture it was just a fool's errand. But then you look at Wren in 1896.
Well, yeah, Wren is huge.
He shatters that dogma by reporting the very first successful repair of a cardiac injury. It was a stab wound to the right ventricle.
Wow.
He actually sutured a bleeding human heart, and the patient survived. That completely changed the paradigm of what was surgically possible.
And the anatomical approaches evolved incredibly fast right after that, didn't they?
They did, almost immediately.
Just 1 year later, in 1897, Duval describes the median sternotomy incision, taking a saw right down the middle of the chest plate. That's an approach that cardiothoracic surgeons still use every single day.
A true staple of the OR.
Right. Then, in 1901, Igles-Rudd successfully resuscitates a patient from post-traumatic cardiac arrest using a thoracotomy and open massage. But for us, for the trauma surgeon in the ED...
The real game changer.
Exactly. The real architectural foundation drops in 1906. A surgeon named Spangereau describes what he called an intercostochondral thoracotomy.
Which, a mouthful.
Yeah, today we just call it the left anterolateral thoracotomy. That is the exact Rapid access incision we use right now when seconds matter.
And that surgical evolution continued steadily, merging with the evolution of medical resuscitation. The text points out Zoll introducing external defibrillation in 1956,
Huge.
and Keuwenhoven describing closed CPR in 1960. Those were massive leaps for general medicine. But for the trauma surgeon, the true modern paradigm shift happened in 1961.
That's when it left the OR, right?
Precisely. The moment this procedure left the sterile operating theater and entered the chaos of the emergency room, Dr. Arthur Beale and his colleagues proposed something incredibly radical.
What was their argument?
They argued that any patient experiencing a cessation of cardiac action from penetrating trauma should undergo an immediate resuscitative thoracotomy and cardiac massage, regardless of their physical location.
So whether they were in the OR, the recovery ward, or right there on the stretcher in the ED.
Exactly.
Which is just insane when you think about the infection risks and the lighting and the sheer logistics of doing a major cavitary surgery in an ER in the 1960s.
It was desperate times, desperate measures.
Beale actually advocated for keeping a dedicated surgical instrument tray permanently set up and sterile in the emergency room just for this purpose.
The first trauma cards.
Yeah. And by 1966, he was successfully performing emergency room cardiography. I mean, this history isn't just trivia. It shows how we arrived at a highly standardized, protocol-driven intervention born out of desperate experimental measures.
Precisely. And that standardized intervention has very specific, non-negotiable life-saving objectives. When you make that incision, you are not exploring.
You don't have time to look around.
No, you are executing a mental checklist of absolute physiological priorities. The authors outline these meticulously. Your first objective is the immediate resuscitation of the agonal patient suffering from penetrating cardiothoracic injuries.
Right.
Second, you must instantaneously evacuate any pericardial blood and clot to relieve cardiac tamponade. The heart simply cannot fill if it is being crushed by its own bleeding.
It's like a vice grip.
Exactly.
Oh.
Third, you must achieve definitive control of any thoracic hemorrhage, whether that's from the great vessels or the pulmonary parenchyma.
Fourth is the direct physical repair of the cardiac injuries, the cardiography itself.
The actual suturing, yes.
And fifth, and we are going to spend a lot of time on this, is the cross-clamping of the descending thoracic aorta.
A massive intervention.
Yeah. Sixth is the performance of open cardiac massage. And I want to pause on the sixth point because the physiologic data here is just staggering.
There really is.
The text points out that open cardiac massage, literally taking the heart in your hands and rhythmically compressing it from apex to base, can produce up to 60% of a normal ejection fraction.
60%.
Right. Compare that to closed chest CPR, which in a severely hypovolemic exsanguinating trauma patient generates essentially zero forward flow.
Because there is no volume to push.
Exactly. Open massage is a massive quantifiable improvement. Then seventh, you have the cross-clamping of the pulmonary hilum to control massive pulmonary vessel hemorrhage.
And finally, the eighth objective is utilizing that Hiller cross-clamp combined with aspiration of both ventricles to either prevent or treat massive pulmonary air embolism.
So those 8 objectives form the core operational doctrine of the EDT. But to truly master this procedure, we need to dive deeply into the physiology of the 5th objective, the cross-clamping of the descending thoracic aorta.
This is crucial. For the trauma surgeon, this is perhaps the most physiologically violent and dramatic maneuver you can perform.
Violent is the right word.
The text emphasizes that it is a profound, double-edged sword.
No.
You are intentionally, actively creating massive systemic ischemia to the lower 2/3 of the patient's body in order to save the core.
Let's break down the mechanics of that. I always think of it like sandbagging a burst of a dam.
Great analogy.
Right, so the river is flooding, the water is running out, and you have to save the town square, which in the human body is the heart and the brain.
The vital organs.
So you throw down a massive wall of sandbags across the aorta. The text details the positive effects first. By clamping the aorta just above the diaphragm, you instantly preserve and redistribute the patient's drastically depleted remaining blood volume.
You're forcing whatever blood is left to circulate exclusively to the coronary arteries and the carotid arteries.
Exactly. You are artificially prioritizing the myocardium and the cerebral cortex. Second, if the patient has associated massive abdominal or pelvic injuries, say shattered pelvis or a liver laceration.
That clamp instantaneously reduces that subdiaphragmatic blood loss to a trickle.
It just shuts off the faucet.
and the secondary cardiac effects are just as vital. Third, the text notes that cross-clamping significantly increases the left ventricular stroke work index.
How does it do that?
Well, because the heart is no longer trying to push blood through the massive, low-resistance vascular bed of the entire lower body, the work it does with each beat becomes highly concentrated.
Oh, I see.
And fourth, it actually increases myocardial contractility. Because you are artificially increasing the perfusion pressure to the coronary arteries themselves, the heart muscle suddenly gets a rush of oxygenated blood. This causes it to squeeze harder and more effectively.
So these are the life-saving temporary stabilization effects. This is how you buy time.
My time, exactly.
But, and I have to push back here because buying time implies you have a lot of it. And the text makes it terrifyingly clear that you do not.
Not at all.
You saved the town square, but you completely flooded the farmland. The text explicitly states that the negative physiologic effects of the cross-clamp are devastating. Let's look at the numbers.
They're grim.
The moment those jaws lock down on the aorta, you are decreasing blood flow to the abdominal viscera, the bowels, the liver, the spleen, to approximately 10% of normal.
10%.
You are decreasing renal perfusion to the kidneys to roughly 10% of normal, and critically, you are dropping arterial blood flow to the spinal cord to about 10%.
So you are plunging the lower half of this patient into rapid, profound anaerobic metabolism. The cells are starved of oxygen, ATP production halts, and they start churning out massive amounts of lactic acid.
Yeah, you're absolutely right to highlight the severity of this ischemia. You are essentially inducing a massive controlled stroke to the spinal cord and a controlled infarction to the bowels and kidneys.
But perhaps the most immediate danger is to the heart itself.
Wait, I thought we just said it helped the heart.
We did say the cross-clamp increases coronary perfusion, but it also imposes a tremendous crushing afterload onto the left ventricle.
Ah, because of the clamped pipe.
Exactly. The heart is suddenly asked to pump against a clamped dead-end pipe. If that left ventricle is already injured, hypovolemic and acidotic, this massive spike in resistance can precipitate acute, catastrophic left ventricular failure.
The heart simply blows out against the pressure.
It does.
Exactly. And that brings up the most terrifying line in the entire text regarding the cross-clamp. It says the exact length of safe cross-clamp time is an unknown factor.
An unknown factor.
How is a surgeon supposed to operate with that? How do you balance this massive LV afterload combined with severe systemic ischemia when the safe limit is literally a question mark?
If we connect this to the bigger picture, you balance it with sheer unrelenting speed. The unknown safe time is exactly what separates a successful resuscitation from a delayed mortality.
So you just have to move as fast as humanly possible.
You have to assume that every minute the clamp is on, irreversible damage is compounding, and you must anticipate the next major threat, which is the reperfusion injury.
Right, because eventually you have to take the clamp off.
Exactly. The authors clearly list the incidence of reperfusion injury as another dangerous unknown. Think about the physiology of declamping. The moment you achieve cardiac repair and volume resuscitation, you take that clamp off.
And then what happens?
When you do, a massive volume of highly acidic, hypoxic blood loaded with inflammatory mediators, potassium, and microemboli from the ischemic lower body washes directly back into the central venous circulation.
It's just a toxic tidal wave hitting the right atrium.
Precisely. This reperfusion injury triggers profound systemic vasodilation. The blood pressure you just fought so hard to restore can instantly bottom out.
Because all the vessels dilate at once.
Yes. Furthermore, that toxic blood causes direct myocardial depression. The heart, which was just recovering, gets hit with an acid load that impairs its ability to contract.
And it messes with the clotting.
Completely. The inflammatory mediators destroy the clotting cascade, inducing a massive coagulopathy. The cross-clamp is not a destination. It is a highly precarious, structurally unstable bridge to definitive repair.
The exact second that clamp goes on, the clock on multi-system organ failure begins ticking so loudly it should deafen everything else in the room.
Well said.
Which perfectly sets up our next critical phase, strategic access and the lethal pitfalls of damage control. Because if you know the profound, irreversible physiologic cost of that cross-clamp, then you know your surgical access has to be flawless.
No room for error.
You cannot fumble the incision. How do we physically get in, and what traps lie waiting for the unwary trauma surgeon?
The text gives us incredibly clear, situationally dependent guidance on incision selection here.
Let's start with the absolute workhorse, the left anterolateral thoracotomy, Spangura's incision. The authors are explicit here. This is the incision of choice in the management of patients who arrive in extremis.
If they are losing pulses, if they are agonal, this is what you do.
And let's walk through the physical reality of that incision. You are making a massive cut in the fifth intercostal space, usually starting just lateral to the left sternocostal junction.
And extending violently outward.
Yeah, you follow the curve of the rib all the way down to the latissimus dorsi muscle in the mid-axillary line. You are incising through the skin, the subq fat, the pectoralis major, the serratus anterior, in the intercostal muscles, straight into the pleural cavity.
Right. And then you insert a funicato rib retractor.
With the crossbar directed toward the axilla to keep it out of your operative field.
Exactly. And you forcefully crank those ribs apart. This gives you immediate, unparalleled access to the left hemithorax, the pericardial sac, the anterior surface of the heart, and crucially, the descending thoracic aorta resting against the spine.
It's brutal, but it's incredibly fast. But the text contrasts this with the median sternotomy, or Duval's approach. And the distinction here is vital for patient selection, right?
It is. The authors state that a median sternotomy is the incision of choice for patients admitted with penetrating precordial injuries wounds to the cardiac box.
But only if they arrive with some degree of hemodynamic stability.
That is the key differentiator. Hemodynamic stability.
Right. If the patient's pressure is 60, but it's holding at 60, they are hypotensive, but they aren't completely arresting.
Yes. They have enough pressure to allow for a rapid, focused preoperative investigation, like a fast exam to confirm pericardial fluid or a portable chest radiograph.
And this is also the incision of choice for patients suspected of harboring occult cardiac injuries who aren't currently pratching.
If the patient is in extremis, losing vital signs, you do the left anterolateral right there in the bay. But if they are holding a pressure, you do not crack them in the ED.
You take them upstairs.
You rapidly transport them to the operating room for a formal median sternotomy. You take a sternal saw, starting at the sternal notch, and divide the sternum vertically down through the xiphoid process.
And there's a clinical pearl here about the lungs, right?
A critical surgical pearl. You must coordinate intimately with your anesthesiologist. Just before you run that saw, you have anesthesia completely halt pulmonary ventilation.
To drop the lungs.
Yes. You want the lungs deflated and falling away from the midline to avoid causing massive iatrogenic pleural or lung parenchymal injury with the saw blade.
That makes perfect sense.
Right.
But let's go back to the crashing patient in the ED. You've done the left anterolateral incision. You are in the left chest. But what if that isn't enough?
What if the trajectory is wider?
Yeah, what if the patient has a gunshot wound that entered the left chest, but the trajectory suggests it crossed the mediastinum and tore into the right lung or the right atrium?
A true nightmare.
The text provides a definitive algorithm for this exact scenario. You must convert that left anterolateral thoracotomy into a clamshell incision.
Also known as bilateral anterolateral thoracotomies.
Yeah.
You literally take heavy Labsch knives or trauma shears and transect the sternum horizontally.
You just cut right across the bone.
Right across, extending your original incision across the midline and down the right fifth intercostal space. You then place 2 rib retractors and elevate the entire anterior chest wall like the hood of a car.
It really is like opening a car hood.
It provides total panoramic exposure of the anterior mediastinum, the entire pericardium, the great vessels, and both right and left hemithoracic cavities. It is the ultimate access maneuver.
But right here, right at this exact step, the text drops an absolutely massive clinical pearl. It is a lethal pitfall that we really have to emphasize because it kills patients who have otherwise been successfully resuscitated.
The mammary arteries.
Yes. When you sharply transect that sternum to create the clamshell, you are cleanly severing both internal mammary arteries.
And this is a devastating point of failure in damage control surgery. The authors explicitly warn that upon transection of the sternum, both internal mammary arteries must be identified and securely ligated.
But here is the insidious part, and tell me if I'm interpreting the physiology right. When you make that cut across the sternum, the patient is essentially dead.
Clinically, yes.
They are profoundly hypotensive, likely in full cardiac arrest, receiving CPR. Because their systemic vascular resistance is so low and they have no pressure, those severed internal mammary arteries simply do not bleed.
They might spasm slightly, but they are completely dry.
So the surgeon, focused on the massive hole in the heart, doesn't even notice them.
Your interpretation is exactly correct. They don't bleed during the crisis. But think about the timeline of success. Let's say you execute a perfect cardiography. You repair the heart.
You resuscitate with massive volume.
Right. You release the aortic Croft clamp, the heart takes over, And suddenly, you restore a systemic perfusion pressure of, say, 110/70.
The moment that pressure hits the peripheral vascular tree.
Those unligated internal mammary arteries blow wide open. They become high-pressure arterial fire hoses bleeding directly into the open chest cavity, or worse, into the closed chest cavity if you've already rushed a temporary closure.
The text states that, uncontrolled, they serve as a massive, significant source of blood loss.
It is a tragically frequent pitfall. The surgeon sends the stabilized patient up to the ICU, only to see the chest tubes instantly dump a liter of fresh, bright red blood.
Oh, man.
This forces a devastating emergency return to the operating room. But now, you're taking back a patient who has consumed all their clotting factors, who is profoundly hypothermic from the open chest and cold blood products, and who is severely acidotic.
They are deep in the coagulopathy of trauma.
Exactly. They simply cannot tolerate another surgical insult. They will bleed to death from every tissue plane.
So what's the takeaway?
Therefore, the ligation of the internal mammary arteries with heavy silk ties or figure-of-8 sutures must be an automatic, unthinking muscle memory reflex the very absolute second you transect that sternum.
You tie them off immediately. Okay, let's move deeper into the chest. We have access. We've avoided the mammary artery trap. Now we have to talk about adjunct maneuvers.
The good, the bad, and the abandoned.
Right. For a bit of historical color, the authors mention Sauerbruch's 1907 maneuver. He suggested controlling massive cardiac hemorrhage by reaching in and physically compressing the base of the heart with your hands to occlude venous return.
Just grabbing the base of the heart.
Yeah. The text notes this is incredibly difficult to achieve via a left anterolateral approach, has been completely abandoned by modern trauma surgeons, and is mentioned purely for historical interest.
Good to know, but don't do it.
Exactly. So let's focus on the maneuvers you will actually use to save a life, starting with total inflow occlusion.
Total inflow occlusion is a highly complex, high-risk maneuver utilized to manage devastating injuries in the lateralmost aspect of the right atrium or at the superior and inferior atriocaval junctions.
So imagine a large tear right where the vena cava meets the atrium.
Yes. You cannot simply throw a clamp on the atrium itself because the tear involves the great vessel. So you must completely stop all blood from entering the heart.
How do you do that?
You do this by cross-clamping both the superior vena cava and the inferior vena cava in their intrapericardial locations using non-crushing Crawford-DeBakey vascular clamps. This instantaneously arrests all venous return.
So the heart just empties out.
Within a few beats, the heart completely empties itself of blood. It goes flaccid, giving you a bloodless, perfectly visualized feel to repair the complex laceration.
But the expert warnings from the authors here are severe. I mean, they practically scream off the page.
The warnings are severe because the margin for error is virtually non-existent. First, you have a massive anatomical danger. The authors highlight the extreme treachery of attempting to cross-clamp the intrapericardial inferior vena cava.
That specific area is known as the space of Gibbons, right?
Yes, the space of Gibbons.
Yep.
The delicate, thin-walled IVC here is often tightly fused with the posterior tough aspect of the pericardium.
Which makes clamping it blindly super dangerous.
Exactly. In the heat of the moment, an inexperienced panic trauma surgeon trying to achieve rapid occlusion will frequently force the jaws of the clamp blindly, or try to aggressively, circumferentially dissect the IVC free.
And what happens?
This almost universally leads to a catastrophic iatrogenic avulsion or tearing of the IVC at the diaphragm level.
Which is an entirely new, massive venous hemorrhage that you just created.
Right. The clamp must be placed with extreme care, sometimes applied partially or at a specific angle, to achieve occlusion without tearing the vessel.
But even if you place the clamps perfectly, you face the second insurmountable wall. The profound physiologic tolerance limit of the myocardium.
Time is not on your side.
The text explicitly states that the injured, acidotic, hypothermic, and ischemic heart has a very, very limited tolerance for total inflow occlusion. The text mentions a window of 1 to 3 minutes.
It is terrifying.
3 minutes to identify a complex caval-atrial junction tear, place sutures, tie them down, and remove the clamps. What happens mechanically if you hit minute 4?
If you exceed that 3-minute limit, the cellular damage within the myocardium crosses a threshold. When you finally release the clamps, massive volumes of venous return aggressively distend the right atrium and right ventricle.
It just balloons up.
The heart wall stretches. The electrical conduction system, which has been completely starved of oxygen, tries to generate a coordinated contraction, but it can't.
The muscle fibers are too ischemic.
So instead of a coordinated beat, the heart simply fibrillates. It looks like a bag of rising worms.
Oh, man.
You will have to resort to direct, open-chest internal defibrillation with paddles set to 20 to 50 joules, combined with massive pharmacological manipulation, epinephrine, amiodarone, lidocaine.
And does that usually work?
The grim reality is if that 3-minute ischemic window was significantly exceeded, the restoration of a normal sinus rhythm is often impossible. The engine is simply too flooded and starved to restart.
Speaking of complex maneuvers and terrifying windows, let's look at another crucial adjunct detailed in the text: cross-clamping the pulmonary hilum.
This is an important one.
Yeah, this isn't for the heart. This is indicated for severe associated pulmonary injuries. If you open the chest and see a massive expanding central hematoma at the root of the lung, or there is exsanguinating active hemorrhage from the lung tissue itself that you can't control with pressure, you clamp the entire hilum.
You grab the pulmonary artery, the pulmonary veins, and the mainstem bronchus all at once.
And this achieves two things immediately, right? It arrests the massive bleeding, and critically, it prevents deadly air emboli from entering the pulmonary veins and traveling to the left heart.
But again, the physiologic cost is immense and immediate. Think about the plumbing. By clamping the entire left pulmonary hilum, you are instantaneously obliterating 50% of the total available pulmonary vascular bed.
So half the lungs are gone, functionally.
Exactly. The right ventricle, which was just pumping blood to 2 lungs, is suddenly pushing against a brick wall on the left side. The afterload on the right ventricle spikes massively and instantaneously.
And we are dealing with a patient who is already suffering from severe trauma-induced acidosis and hypothermia.
All right, their heart is already struggling.
The right ventricle, which is relatively thin-walled compared to the left, simply isn't built to handle that kind of sudden pressure spike. The text notes that the RV may rapidly distend and fail, leading directly to, you guessed it, intractable fibrillation and cardiac arrest.
To mitigate this lethal spike in right-sided afterload, the authors provide a very specific, modern surgical recommendation. You cannot leave the entire hilum clamped while you slowly explore the lung.
They advise sequential rapid declamping of the hilum, right?
Yes, immediately combined with the direct surgical approach utilizing a stapled pulmonary tracheotomy.
Let's explain what a tracheotomy actually is, because it sounds brutal, but it's incredibly elegant.
It really is. Instead of trying to perform a formal anatomical lobectomy in a crashing patient, which takes too long, you take a massive surgical stapler like a GIA 75 or TA 90.
And you just fire it into the lung.
You insert one jaw of the stapler directly into the penetrating wound tract in the lung tissue and the other jaw on the outside. When you fire the stapler, it cuts through the lung tissue along the bullet tract while simultaneously laying down parallel rows of titanium staples, sealing the lung parenchyma on both sides.
You literally open the bullet tract like a book.
Exactly. This allows for the rapid, direct visualization and specific individual ligation of these severed, bleeding, interparenchymal pulmonary vessels lying at the bottom of the tract.
It's brilliant. You find the exact bleeding vessel, tie it off, and you're done. And why is this so physiologically important compared to just leaving the hilum clamped?
Because the moment you control those specific vessels, you can completely remove the hilar clamp. This promptly unloads the right ventricle, restoring forward blood flow through the undamaged portions of the lung and instantly reducing that crushing right-sided afterload before the ventricle fails.
You mentioned air emboli earlier when we were talking about clamping the hilum to prevent them. The text contains some absolutely chilling visual descriptions of this, specifically referencing Figure 8.
The visual of the bubbles.
Yes. They describe the surgeon opening the pericardial sac. Because the patient is profoundly hypotensive and exsanguinated, the coronary arteries and veins on the surface of the heart are severely vasoconstricted and flat.
And then the surgeon sees it.
The terrifying sight of air emboli clearly visible as segmented bubbles traveling within the coronary veins.
The pathophysiology here is fascinating and deadly. A laceration in the lung parenchyma allows air from the bronchioles, under positive pressure from the anesthesiologist's ventilator, to be forced directly into the torn pulmonary veins.
It just pumps the air straight into the blood.
These air bubbles travel to the left atrium, the left ventricle, and are instantly pumped out the aorta and directly into the coronary arteries. The text notes that these air emboli create an immediate, complete vapor lock.
A vapor lock?
Yes, a temporary but absolute occlusion to forward blood flow in the coronary microcirculation. You generally cannot see the bubbles in the coronary arteries themselves because the arterial walls are too thick and muscular. You only visualize them once they cross the capillary bed and enter the thinner-walled coronary veins.
And the text states unequivocally, the visual confirmation of air emboli in the coronary veins is a massive, independent predictor of a severely poor outcome. It is a harbinger of death.
An air embolus in the coronary circulation acts exactly like a massive, sudden-onset myocardial infarction. It completely halts distal oxygen perfusion, leading to localized, severe ischemia.
And that leads to the dysrhythmias again.
The affected myocardial tissue becomes highly irritable, leading to intractable, malignant dysrhythmias. The heart simply refuses to beat in an organized fashion while those bubbles are present.
So what do? I mean, you can't just stare at the bubbles.
No, you must act instantly.
The authors provide an immediate, actionable, clinical parole for this nightmare. If you suspect or physically visualize air emboli, you must actively vent the ventricles.
You do this by taking a standard 16-gauge intravenous catheter, the same kind you'd use to start a line in the arm, and you stab it directly into the apex of the affected left or right ventricle.
And what does that do?
Theoretically, as the heart attempts to squeeze, the entrapped air will preferentially eject out through the open catheter hub into the atmosphere, clearing the vapor lock in the coronary circulation and allowing blood to flow again.
It is a desperate, critical rescue maneuver. But, speaking of maneuvers, we must address the Grabowski maneuver.
Oh, yes.
The text brings this up specifically to emphatically warn against its use. Dr. Grabowski described a technique for accessing posterior cardiac wounds on the back of the heart that you can't easily see.
He advocated placing a Setinsky partial occlusion clamp directly onto the right ventricular angle.
This is the acute anteroinferior margin where the right ventricle reflects against the right diaphragm, right?
Exactly. The idea was to firmly grasp a small portion of the right ventricular muscle with the clamp, and then use the clamp like a joystick to physically elevate and rotate the beating heart up out of the pericardial well, exposing the posterior aspect.
If I have a patient exsanguinating from a posterior wound, my first instinct is exactly that. Grab the heart, lift it up, find the hole.
It's a natural instinct, but it's wrong.
The authors of this text are absolutely definitive in their stance here. They state they have zero experience with this maneuver and they strictly, unambiguously cannot recommend it. Why? What happens mechanically when you throw a clamp on the RV angle and haul the heart upwards?
The authors strongly feel that applying a rigid vascular clamp directly to the ventricular myocardium, especially if used to physically torque or manhandle the heart, will almost certainly lead to the immediate development of uncontrollable, significant cardiac dysrhythmias.
It just pisses the heart off.
You have to remember the state of this myocardium. It is ischemic, it is acidotic, it is highly irritable. If you crush a section of that muscle with a clamp and stretch the conduction pathways by forcefully lifting the organ, the electrical system shorts out. It triggers VFib. The irritated myocardium will instantly devolve into coarse ventricular fibrillation. You might expose the posterior wound, but you just killed the pump.
So, to put you on the spot, how do you elevate the heart for a posterior wound if you are forbidden from clamping it and lifting it? You still have to fix the hole.
The text acknowledges this exact dilemma. Rapid, injudicious manipulation of the heart will result in complex dysrhythmias, but exsanguinating hemorrhage must be stopped.
So what's the middle ground?
The authors advise a much more measured approach. First, you must establish constant, direct communication with your anesthesiologist, warning them that you're about to manipulate the heart and to prepare for pressure drops and dysrhythmias.
Always keep anesthesia in the loop.
Always. If the hemorrhage can be initially controlled blindly with digital pressure, simply finding the hole with your fingers and plugging it, do that first. Then, they recommend the gradual, supported elevation of the heart.
You don't pull it up, you push it up from below.
Exactly. You carefully slide multiple soft laparotomy packs behind the heart, one by one. This slow, broad-based, supported elevation allows the myocardium to dynamically adjust to the displacement.
That makes a lot of sense.
It significantly decreases the mechanical strain on the tissue and minimizes the chances of triggering a lethal dysrhythmia compared to abruptly hauling it into the air with a metal clamp.
It's about respecting the profound irritability of the traumatized myocardium. You have to treat it like a bomb.
A very fragile bomb.
This transitions perfectly to the actual art of cardiography. The physical, mechanical repair of the bleeding heart, the techniques, the instruments, and the sutures vary wildly depending on which specific chamber you are addressing.
Let's start with the low-pressure systems. Atrial injuries.
The atria receive blood, they don't pump it systemically, so the pressures are low. But the trade-off is that their muscular walls are notoriously thin, delicate, and incredibly fragile.
Exactly. The text recommends controlling an atrial injury first by gently placing a Satinsky partial occlusion vascular clamp around the laceration.
Just to pinch it off.
Because the atrium is pliable, you can gather the torn edges together and clamp them, completely isolating the injury while still allowing venous blood to flow past the clamp and into the ventricle.
For the physical repair, the authors recommend using 2-0 or 3-0 polypropylene monofilament sutures like Prolene, right?
Yes, you want it on an MH needle, which has a specific half-circle arc that is easy to rotate in tight spaces. You can place the sutures in either a running continuous fashion or a simple interrupted stitches. But crucially, they emphasize the need to fully visualize both sides of the atrial injury, especially with missile wounds.
Why is that so important?
Because the tissue destruction from a bullet can be remarkably extensive and jagged. You might see a clean hole on the outside, but the intimal layer on the inside could be shredded.
And if you don't fix the inside?
If you just quickly sew over the top, the inside continues to bleed or form clots. You often require meticulous surgical debridement of the necrotic edges before you can even attempt closure. Sometimes the tissue is so macerated that a portion of the atrial appendage must be outright sharply resected, amputated, and then the clean edge is closed.
And the text gives a very specific, bolded warning about atrial repairs. Under no circumstances should you use bioprosthetic materials. Do not use Teflon pledgets on the atria.
A fatal error.
Right. I can imagine an inexperienced surgeon thinking, the tissue is thin, I should reinforce it with Teflon, but the expert consensus says that is a fatal error. Why?
It comes down to the physics of the tissue. The trauma surgeon must be incredibly gentle because the atrial tissue tears almost like wet tissue paper. If you try to use Teflon pledgets here, you're introducing a rigid, unyielding foreign body against a thin, dynamic, friable wall.
So it doesn't bend with the tissue.
Right. When the atrium fills and stretches, the rigid Teflon pledget doesn't give. Instead, it acts like a saw. The suture will pull the rigid pledget right through the delicate atrial wall, massively and catastrophically enlarging your original injury. Teflon is strictly for the thick, muscular ventricles, never the atria.
Let's move to those ventricles then. The dynamics there are completely the opposite. The right and left ventricles are high-pressure, thick-walled, muscular pumps.
When there is a ventricular injury, you aren't dealing with a slow ooze. You are dealing with significant, pulsating, high-velocity hemorrhage shooting across the room.
The text says you cannot use a Satinsky clamp here. The muscle is too thick. You must first achieve immediate brute force control via digital occlusion, literally jamming your finger over or directly into the laceration to plug the leak.
And to repair it, you use simple interrupted sutures or horizontal mattress sutures of Halsted, again, utilizing 2-0 polypropylene on a curved MH needle.
And we have to address the contrast in injury mechanisms because it dictates your surgical technique. The authors note that performing cardiography for a simple ventricular stab wound, say, from a knife or an ice pick, is generally much less challenging than dealing with a gunshot wound.
A knife just parts the muscle fibers. A bullet destroys them.
Exactly. It is due to the physics of high-velocity missiles. When a bullet passes through the thick ventricular myocardium, it transfers massive kinetic energy, creating a temporary cavitary blast effect.
This blast wave causes the surrounding myocardial muscle fibers to violently retract, swell, and become highly necrotic and friable over the next few minutes. It turns healthy muscle into bloody mush.
So a normal stitch just won't hold.
Right. You might place what looks to the naked eye like a perfect hemostatic deep mattress suture line. But as the damaged myocardium continues to actively retract and die, that successfully sutured wound can suddenly give way.
The tension of the beating heart will tear your sutures right out of the mushy tissue, suddenly recreating a massive hole.
This is exactly where those bioprosthetic materials become absolutely mandatory. The authors dedicate significant text to detailing the use of Teflon strips or pledgets to buttress the suture line in these complex, friable ventricular wounds.
The technical description in the text is intense. Let's walk through the actual hand movements of this repair.
It requires extreme coordination between the surgeon and the assistant. The surgeon rapidly fashions a small Teflon strip, cutting it to measure anywhere from 1 to 5 centimeters, depending on the wound size.
And what does the assistant do?
The assistant then takes 2 straight creel clamps, grasps the ends of the Teflon strip, and presses it firmly and flatly down, directly over the actively bleeding ventricular injury, temporarily achieving hemostasis.
Okay, so the hole is covered. Then what?
The trauma surgeon then takes a double-armed 2-0 polypropylene suture, meaning there is a needle on both ends of the thread. The surgeon passes the first needle down through the Teflon strip, deep through the healthy myocardium on one side of the injury, crosses under the actual laceration, and brings it up to the healthy myocardium on the other side.
It has to go deep enough to get purchase on healthy muscle, not just the necrotic edges.
Precisely. Then a second Teflon strip is held firmly on the opposite side of the wound, and the surgeon passes both needles up through that second strip.
Wow, so you're sandwiching it.
When the surgeon gently but firmly ties those sutures together, they are not tying the thin thread directly against the soft muscle. They are tying the knot against the rigid Teflon pledgets.
These pledgets act like snowshoes. They distribute the intense tension of the suture across a much wider surface area of the friable muscle, physically preventing the suture thread from acting like a wire and cutting through the tissue.
It's structural engineering applied to a beating heart. And the authors note this complex maneuver must be repeated, placing multiple pledgeted sutures until total, absolute hemostatic control is achieved.
They also mention that in the modern trauma bay, we have adjuncts like commercially made fibrin sealants advanced surgical glues that can be sprayed over the final repair to help seal the microscopic weeping bleeding from these complex ventricular injuries.
It is a highly meticulous, high-stress repair. And the text notes it becomes exponentially more complicated and potentially lethal if the penetrating injury is located anatomically adjacent to a major coronary artery.
The text provides strict, unforgiving anatomical guidelines here.
Because if you just blindly throw a deep mattress suture to close the muscle, you might grab the artery too.
Exactly. Injudicious, rushed placement of a deep myocardial suture can easily encircle and ligate a major coronary artery, such as the left anterior descending.
The LAD.
Right. If you tie that down, you instantly cause a massive iatrogenic myocardial infarction. You fix the hole, but you kill the heart.
Therefore, the authors instruct that the needles must be passed deeply, intentionally navigating underneath the anatomical bed of the coronary artery, physically lifting the artery away from the repair site so it remains patent.
But what if the bullet didn't just miss the artery? What if the bullet directly lacerated the coronary artery itself? The text breaks down the management of direct coronary artery injuries by their anatomical segment, and the options are grim.
They are very grim. If you have an injury to the distal-most third of a coronary arteryway down near the apex of the heart, the text states it can generally be safely managed by simple, direct surgical ligation. You just tie off the bleeding artery.
Because it's a small area.
Yes, the volume of myocardial muscle mass supplied by that distal segment is relatively small, and it can usually tolerate the resulting localized ischemia without causing the entire pump to fail.
But if that injury is higher up, in the middle segment of the artery, the text explicitly warns that desperate ligation will result in immediate, intractable table death from a massive hemispheric myocardial infarction. You cannot tie off the midsegment.
The authors state that these mid-segment injuries may require immediate, emergent cardiopulmonary bypass.
Or if the patient miraculously survives the initial temporary repair in the ED, they require the immediate institution of intra-aortic balloon counterpulsation to support the failing heart, followed by an emergent rush to the OR for an aortic coronary bypass graft ABG.
And if the penetrating injury is to the proximal segment of a major coronary artery, right off the aorta, the text is blunt. It will almost certainly require immediate cardiopulmonary bypass for any hope of repair.
Which you just don't have time for.
Though the authors grimly note this is infrequently necessary in practice because patients with proximal coronary artery transections almost never survive the ambulance ride to reach the hospital.
The mortality is just too fast. While we are talking about pitfalls and improvised repairs, the text mentions what to do if you don't have Teflon pledgets readily available.
The pericardial flap.
Yeah, you can use autogenous materials. The surgeon can sharply harvest a small flap of the patient's own pericardial sac to use as a makeshift pledget, but the authors highlight a terrifying trap for the inexperienced panic surgeon here.
It's a trap born of rushing. If you don't fully excise the piece of pericardium, or if you aren't paying close attention to your needle pathways, you might inadvertently suture the main body of the intact pericardial sac directly to the ventricular injury during your repair.
By doing this, you physically tightly fixate the dynamically beating ventricular chamber to the rigid wall of the pericardial sac.
You tether the heart.
You tether it completely. This severely mechanically restricts the heart's natural rotational and pumping motion.
And what's the result of that?
It creates a focal point of extreme mechanical stress on the myocardium with every single beat, which invariably, predictably, leads to intractable, malignant dysrhythmias. The heart will simply fibrillate because it cannot move naturally. That is an iatrogenic pitfall that must be recognized and avoided at all costs.
This is a perfect time to take a breath and reflect on the staggering, overwhelming physiologic toll this entire sequence of events takes on the human body. The authors brilliantly encapsulate this cumulative trauma in their description of Figure 18.
A lethal tetrad.
They detail a specific case study of a patient who sustained multiple devastating gunshot wounds. This patient required a complex left ventricular cardiography using multiple Teflon pledgets, followed by a non-anatomic lung resection to control hemorrhage, and finally, repair of a shattered superior femoral artery.
The authors state that this patient experienced what they have officially termed the lethal tetrad of Asensio.
This is a paramount concept for the critical care surgeon. Every medical student is taught the classic trauma triad of death: profound acidosis, severe hypothermia, and uncontrollable coagulopathy.
These three factors feed into each other in a vicious downward spiral.
Dr. Asensio and his colleagues, based on their massive experience, have updated this paradigm specifically for the cardiothoracic trauma patient. They added a fourth, definitive, and often fatal element: the onset of intractable cardiac dysrhythmias and cardiac arrest, requiring multiple desperate defibrillations and aggressive pharmacological manipulations.
Why does the heart become the fourth pillar of death here?
Because when a patient enters the lethal tetrad, their myocardium is subjected to the ultimate stress test. It is deeply starved of oxygen due to exsanguination. It is physically freezing cold from the open chest exposure and the rapid infusion of refrigerated blood products.
And it's bathing in acid.
It is bathing in highly acidic blood due to systemic anaerobic metabolism. And it is poorly perfused because the coronary pressure is marginal. Under these extreme conditions, the cellular resting membrane potentials become chaotic.
The heart becomes electrically unhinged.
Managing the surgical anatomy, placing the perfect Teflon pledget, is only half the battle. If you, as the critical care physician, cannot simultaneously reverse the physiologic components of the lethal tetrad, if you can't warm them, correct the pH, and give them calcium and clotting factors, the patient will die of an intractable arrhythmia right there on the table, regardless of how mechanically beautiful your suture line is.
Here's where it gets really interesting, and I love this part of the text because it points directly toward the future of managing these exact nightmare scenarios. Imagine you have a patient deep in the lethal tetrad.
Okay.
They are highly tachycardic, their heart rate is 140, they are hypotensive, and they have a friable, actively tearing ventricular wound. Trying to manually place a delicate mattress suture in that thrashing, bloody mess is nearly impossible.
Almost guaranteed to tear.
The text highlights a fascinating, groundbreaking case report by Waterworth. This represents the ultimate crossover of elective, highly controlled cardiothoracic technology into the absolute chaos of the trauma bay.
It is a remarkable piece of literature. Waterworth reported the emergency use of the Octopus the Thief mechanical cardiac stabilizer.
What is that exactly?
For context, this is a sophisticated medical device routinely used in elective, calm, off-pump coronary artery bypass grafting in the sterile OR. Its sole purpose is to hold a small section of the beating heart perfectly still so the surgeon can sew tiny vessels.
And Waterworth brought this down to the ED?
Waterworth brought this device down to the ED and applied it to a 20-year-old trauma patient in extremis.
The specifics of the injury are what make it so compelling. The patient had a 2-centimeter penetrating stab wound located in the right ventricular outflow tract, literally just 1 centimeter below the delicate pulmonary valve.
A very tricky spot.
This is an anatomically dense, highly mobile, and incredibly fragile area. And the patient was wildly tachycardic. Every time the surgeon tried to manually approximate the edges of the wound with forceps to place a stitch, the rapid, forceful beating of the heart caused the tissue to tear further.
So instead of risking the fatal dysrhythmias associated with manual elevation or blind clamping, the surgeon deployed the Octopus the Fourth.
How does it work on the heart?
This device has 2 adjustable arms with specialized suction foot blades. The surgeon placed these blades directly onto the epicardial surface of the myocardium, flanking the wound. When the suction was engaged, the blades firmly adhered to the heart muscle, providing absolute rock-solid mechanical immobility to that specific 3-centimeter area of the violently beating heart.
And the rest of the heart just keeps beating.
The rest of the heart continued to pump, maintaining perfusion, but the operative field was perfectly still.
And the text notes an amazing mechanical side effect of this. By positioning the device parallel to the direction of the stab wound, the surgeon can gently squeeze the arms of the device together, approximating the suction foot plates.
It pulls the wound closed.
This action physically pulls the torn edges of the myocardial wound together, achieving near-total mechanical hemostasis without a single stitch. It provided a perfectly clear, bloodless, motionless field for the surgeon to calmly and precisely place the definitive sutures without tearing the surrounding tissue.
The authors of our foundational text note that this appears to be the first, and currently only, reported case in the literature utilizing an advanced mechanical cardiac stabilizer for a penetrating cardiac injury directly in the ED.
It is a brilliant, improvised application of cross-disciplinary technology.
This raises an important question about the standardization of our trauma carts. We know that manually manhandling the heart induces the dysrhythmias of the lethal tetrad. If mechanically stabilizing the myocardium with suction can prevent those dysrhythmias and facilitate the rapid repair of friable tissue, we must seriously debate whether devices like the octopus Thafith should transition from elective OR tools to standard, immediately available armamentarium for the trauma surgeon.
It's a tantalizing glimpse into the future of resuscitation, but let's step back into the present reality. We've exhaustively covered the history, the crushing physiology of the cross clamp, the pitfalls of access, and the intricate, heroic mechanics of cardiography.
The fun stuff.
But as evidence-based U.S.-trained surgeons, you have to look at this massive physiological insult and ask the hard, cold questions. Who actually survives this? What does the objective data tell us about patient selection?
The grim reality of the stats.
And crucially, when are we simply performing a futile, massively expensive, resource-straining procedure on a corpse? This brings us to the statistical reality check and the methodologies of the literature that guide your practice.
And we must start by acknowledging that the text is highly critical of the existing body of literature. The authors point out that the medical archives abound with vast retrospective series describing the outcomes of the emergency department thoracotomy.
But there's a problem with that data.
A massive problem. Rigorously evaluating these results to form clinical guidelines is incredibly difficult due to massive systemic methodological flaws. Almost the entirety of the historical data is Class 3 retrospective data.
Just looking backwards.
Many of these reports emanate from smaller institutions that rarely perform the procedure, meaning the surgical expertise is highly variable. Furthermore, the studies overlap wildly in timeframes, encompassing decades of rapidly changing pre-hospital EMS protocols, transport times, and fluid resuscitation strategies.
You're comparing apples to oranges across different eras of medicine, but the text emphasizes one specific glaring omission in these older studies that makes them almost useless for modern triage.
Yes. The fatal flaw in retrospective trauma research is the failure to capture the initial physiological state of the patient. The text specifically highlights the absence of the cardiovascular respiratory score, or CVRS, in these vast historical series.
Let's define the CVRS for context. It is a validated component of the broader trauma score that assigns objective point values to blood pressure, respiratory rate, respiratory effort, and capillary refill at the moment of presentation.
Exactly. A maximum score of 11 denotes a patient who is relatively stable. A systolic blood pressure over 90, a respiratory rate of 10 to 24, normal unlabored effort, and brisk capillary refill.
And a score of 0.
Conversely, a score of 0 reflects a patient who is biologically dead on arrival.
Wow.
Complete absence of measurable blood pressure, no palpable pulse, no spontaneous breathing, and absent capillary refill. The authors argue that without knowing if a patient in a 1985 retrospective study arrived at the ED with a CVRS of 11 or a CVRS of 0, comparing their surgical outcomes is scientifically meaningless. You cannot establish true predictive values.
You don't know who is salvageable and who is already gone.
Precisely. The authors lament that well-known bedside physiologic predictors of an inevitably poor outcome, like the complete absence of vital signs in the field, fixed and dilated pupils, and agonal, gasping breathing patterns, were simply not tracked, recorded, or reported in the vast majority of the surgical literature over the last 40 years.
Which is exactly what makes the pivotal prospective study led by Dr. Asensio and his colleagues so monumentally vital to modern trauma surgery. The text notes that this is the only prospective study specifically evaluating the use of EDT reported in the literature.
They set it up perfectly.
They didn't look backwards. They set up the parameters beforehand. They prospectively tracked the CVRS, the exact mechanism of injury, the specific anatomic site of the lesion, and whether or not they achieved restoration of blood pressure.
Their explicit goal was to identify objective parameters that reliably predict mortality risk, with the ultimate aim of safely and ethically excluding patients from undergoing a futile EDT.
It was a rigorous undertaking. Over a 2-year period, they prospectively studied 215 consecutive patients who sustained cardiopulmonary arrest secondary to trauma and underwent an EDT.
The demographics of the injuries are telling. 78% of these patients suffered penetrating injuries. That breaks down to 142 gunshot wounds, 21 stab wounds, and 4 devastating shotgun wounds. The remaining 22%, or 48 patients, sustained blunt trauma motor vehicle collisions, falls, crush injuries.
And these were not simply hypotensive patients. These were profoundly, massively injured patients. The text provides their baselines. The mean revised trauma score for the cohort was 0.6 out of a maximum 7.8.
Almost zero.
The mean injury severity score was a massive 42, where anything over 15 is considered major trauma. And critically, the mean CVRS upon arrival in the ED was 1.
The mean duration of pre-hospital CPR before arriving at the bay was 12 minutes. These patients were as close to death as a human can be.
And the statistical results of this prospective cohort are sobering, definitive, and practice-changing. Out of those 215 patients who arrived in cardiopulmonary arrest and received an EDT, 162 succumbed immediately in the emergency department.
The thoracotomy failed to even temporarily restore a rhythm.
53 patients, representing roughly 25% of the cohort, survived for at least 1 hour after successful ED resuscitation and were transported to the operating room for definitive repair.
But the ultimate metric of success in trauma isn't making it to the OR. It is survival to hospital discharge. Walking out the front door, what were those numbers?
Stark. Out of the initial 215 patients, only 6 survived to discharge. That is an overall survival rate of 2.8%, rounding to 3%. And the mechanism of injury was the absolute determining factor. All 6 survivors had sustained penetrating cardiac injuries.
Let me stop you there and repeat the most critical finding for our listeners who are managing blunt trauma, because this should dictate your practice.
The blunt numbers.
Of the 48 patients in this study who presented in cardiopulmonary arrest secondary to blunt trauma, there were exactly 0 survivors. None. Not a single patient survived an EDT for blunt trauma arrest.
The authors then performed rigorous, multivariable statistical analysis on this prospective data to find the true predictors of life and death. When comparing all non-survivors with the 6 miraculous survivors, the data spoke clearly.
Let's hear the p-values.
The successful surgical restoration of blood pressure in the ED was a massive, strong predictor of ultimate outcome, with a highly significant p-value of less than 0.001. A penetrating mechanism of injury, specifically being stabbed or shot rather than crushed, was strongly predictive, also with a p-value of less than 0.0001.
Very strong predictors.
The clinical presence of exsanguination was a strong negative predictor with a p-value of 0.006, and the duration of pre-hospital CPR was significantly predictive with a p-value of 0.04. The longer the CPR, the closer survival approaches 0. Finally, the initial CVRS score upon arrival showed a strong statistical trend toward predicting survival with a p-value of 0.07.
A p-value of less than 0.001 isn't just an academic number to memorize for boards. In the chaos of the trauma bay, that p-value is your clinical shield.
Your shield? How so?
It is the objective mathematical proof that empowers you to call a code and stop a futile procedure. The text explicitly highlights the massive systemic and economic impact of applying these prospectively validated criteria.
Because cracking a chest is resource intensive?
Exactly. The authors concluded that by strictly utilizing these specific physiologic parameters, like the CVRS score and the presence of pre-hospital vitals, they could confidently and safely exclude a full 75% of the patients who, under older, looser protocols, would have undergone a futile, messy EDT.
The implications of that are profound. In their institution alone, implementing these strict exclusion criteria resulted in an immediate direct cost savings of over $500,000. But to be clear, the authors emphasize that this is not primarily about saving dollars. It is entirely about the ethical, responsible allocation of critically finite medical resources.
Exactly. When you perform a futile EDT on a blunt trauma patient with no vitals, You weren't just wasting surgical time. You were tying up the only level 1 trauma bay in the region.
You're eating up the blood bank.
You are consuming massive amounts of uncross-matched O-negative blood products from a blood bank that is likely already stretched thin. You are fully occupying your anesthesiologist, your scrub techs, and your critical care nurses. And by doing so, you are potentially delaying life-saving care for the next salvageable patient coming through the doors.
It is about moving the discipline from an emotional, heroic, desperate response to an intensely evidence-based, protocol-driven surgical decision. And this rigorous prospective data from Asensio fed directly into the massive definitive literature review conducted by the ad hoc subcommittee on outcomes of the American College of Surgeons Committee on Trauma.
The ACS-COT review.
Dr. Asensio served as a key working group member for this committee.
The text summarizes this monumental ACS-COT review, and the scope is incredible. They searched the entire breadth of surgical literature and, unsurprisingly, found 0 Class I prospective randomized controlled trials. As the text notes, this makes perfect sense. You cannot ethically randomize a dying, bleeding patient to receive or not receive a potentially life-saving thoracotomy.
You can't flip a coin on a cardiac arrest.
So they relied on 29 Class II studies and 63 Class III retrospective studies. When they aggregated and analyzed the 42 large series dealing specifically with the outcomes of EDT, they were looking at a massive, unparalleled data set encompassing 7,035 individual procedures.
Over 7,000 attempts.
Out of those 7,000 attempts, there were 551 total survivors. That gives us the definitive overall historical survival rate for the procedure, 7.83%.
And when you stratify that massive 7,000 patient data set by the mechanism of injury, the findings from Asensio's smaller prospective cohort hold absolutely true on a macro national scale.
The numbers don't lie.
Out of 4,482 thoracotomies performed for penetrating injuries, shootings, and stabbings, there were 500 survivors, yielding a survival rate of 11.16%. That is a justifiable, acceptable salvage rate in trauma surgery.
But then look at the blunt trauma numbers.
Right. 2,193 thoracotomies were performed for blunt injuries, car crashes, falls from height. Out of over 2,000 attempts, there were only 35 survivors. That is a dismal, mathematically horrific 1.60% survival rate.
It's essentially anecdotal survival at that point. But let's look at where the procedure shines. The text also breaks down survival specifically for penetrating injuries isolated to the heart itself. Across 47 reports encompassing 11,165 EDTs performed for isolated penetrating cardiac trauma, 363 patients survived.
What's the percentage on that?
That is a robust, highly significant 31.1% survival rate. The conclusion is clear. If the injury is penetrating and the damage is isolated strictly to the cardiac box, the procedure is highly effective and absolutely indicated.
The text also briefly touches on the available pediatric data, which is vital for pediatric trauma centers. They found 4 series covering 142 pediatric EDTs. The numbers mirror the adult data with striking similarity. A 12.2% survival rate for pediatric penetrating trauma and a grim 2.3% survival rate for pediatric blunt trauma. The mechanism dictates the outcome, regardless of the patient's age.
But survival is only one metric. We have to address the most devastating potential outcome of this procedure, which is the ultimate quality of that survival.
The neurologic outcome.
The ACS-COT review specifically looked at 14 series that rigorously tracked the long-term neurologic outcomes of the survivors. This is the heavy ethical burden of the cross-clamp and the prolonged CPR. Out of 4,520 patients subjected to EDT in those specific series, there were 226 survivors.
And how many had deficits?
Of those 226 survivors, 34 patients, or 15% of the total surviving cohort, survived with severe permanent neurologic impairment or in a persistent vegetative state.
That is a staggering statistic that should give every trauma surgeon pause. You are not just responsible for restarting a heart, you are entirely responsible for the neurologic integrity of the life you are saving. Returning a 20-year-old to their family in a persistent vegetative state because you push a resuscitation 15 minutes past the point of severe cerebral ischemia is a devastating outcome.
This specific data, the 1.6% blunt survival, the 31% penetrating cardiac survival, and the 15% severe neurologic impairment rate, is exactly what drives the final, definitive practice management guidelines published by the ACS-COT and detailed at the conclusion of our text.
Let's translate those final dense guidelines into rapid-fire, absolute bedside rules for the trauma surgeon listening to this right now. You are in the bay, the patient rolls in. The TAC breaks the indications down into 3 strict, uncompromising categories. accepted, selective, and rare.
First, the accepted indications.
The text states, EDT is best applied and unequivocally accepted as standard of care for patients sustaining penetrating cardiac injuries who arrive at trauma centers after a short scene and transport time with witnessed or objectively measured physiologic parameters.
And those parameters, those signs of life, must be explicitly defined. We are talking about pupillary reactivity to light, spontaneous ventilation, even if it's irregular or agonal, the presence of a palpable carotid pulse, measurable blood pressure, spontaneous extremity movement, and confirmed organized cardiac electrical activity on the monitor.
If they have a hole in the heart, a short ambulance ride, and they show any of those signs of life in the bay or just prior to arrival, you crack the chest, period. That is your 31% survival cohort.
Next are the selective indications. This is where the survival rate drops significantly and your seasoned clinical judgment becomes paramount. The text advises EDT should be performed selectively in patients with penetrating non-cardiac thoracic injuries.
Why selectively?
Because in a crashing, bleeding patient, it is often clinically impossible to differentiate a massive pulmonary bleed from a true cardiac injury based on an ultrasound or an external wound tract. Therefore, the procedure is employed selectively here as a massive diagnostic tool to rapidly open the chest, establish the exact source of hemorrhage, and attempt control.
Similarly, the text states EDT should be performed selectively for exsanguinating abdominal vascular injuries. Now, this sounds counterintuitive, opening the chest for a belly bleed, but the survival here is very low, and the text demands meticulous patient selection.
It emphasizes that in this specific scenario, the left anterolateral thoracotomy is not used to fix the heart. It is used strictly as a rapid damage control adjunct, specifically to cross-clamp the descending thoracic aorta just above the diaphragm.
This gains immediate proximal vascular control, stopping the bleeding in the belly, before you proceed to a definitive massive laparotomy to repair the shattered inferior vena cava or iliac artery.
And finally, we arrive at the rare indications. Based on the crushing statistical reality we just reviewed, we could honestly retitle this the avoid category. The text states unequivocally that EDT should be performed rarely, if ever, in patients sustaining cardiopulmonary arrest secondary to blunt trauma, owing to its abysmal 1.6% survival rate and the unacceptably high rate of terrible neurologic outcomes.
The authors are incredibly strict here. Extreme caution must be exercised by the surgical team. If you are going to attempt this, the procedure should be strictly limited to blunt trauma patients who arrive with measurable vital signs at the trauma center and experience a witnessed cardiopulmonary arrest right there in your presence in the resuscitation bay.
But if you're standing there and the blunt trauma patient loses a pulse right in front of you and their family is in the waiting room, how do you justify not doing everything in your power? Is a 1.6% chance of survival really a reason to stand back and do nothing?
That is the hardest question in trauma surgery, and it raises a vital point regarding our entire pre-hospital trauma system. The text explicitly notes that most experienced authors would caution against even this rare indication for blunt trauma.
You justify withholding the procedure by understanding the physiology of blunt arrest. Unlike a single bullet hole to the heart, a blunt arrest usually implies massive multi-cavitary hemorrhage, profound brain injury, and total physiological exhaustion.
So if they arrest in the field?
If a blunt trauma patient loses vital signs in the field or in the ambulance, the data strongly, irrefutably, suggests that rapid transport with lights and sirens for an EDT is an exercise in absolute futility. The massive hospital resources expended, the physical danger to the EMS transport crews speeding through intersections, and the biological cost to the patient's dignity must be objectively weighed against a survival rate that mathematically approaches zero. The ACS guidelines are explicitly designed to empower the trauma surgeon to say no, to recognize, based on hard data, when the profound physiologic derangement has surpassed the extreme limits of our current surgical science.
That is a heavy but absolutely necessary reality to confront. It's the hardest part of the job. As we wrap up this massive deep dive, let's synthesize exactly what the U.S.-trained trauma surgeon needs to take away for their next shift.
The takeaways.
The text we've exhaustively analyzed today, authored by Dr. Asensio and his esteemed colleagues, makes it abundantly, aggressively clear. The emergency department thoracotomy is not a panacea. It is not a magic bullet you fire wildly when everything else fails. It is a highly specific, profoundly physiologically taxing surgical adjunct.
Success in the trauma bay requires absolutely strict, protocol-driven, unemotional patient selection. You must rely heavily on the presence of pre-hospital or ED vital signs, the initial CVRS, and a penetrating mechanism of injury to ethically justify the procedure.
Furthermore, if the data supports it and you commit to the procedure, you must execute it flawlessly while navigating a minefield of lethal, hidden pitfalls. You must instinctively, automatically ligate the internal mammary arteries when extending a left thoracotomy to a clamshell.
You must respect the absolute 1 to 3 minute physiological limit on total inflow occlusion at the space of Gibbons, or you will induce intractable fibrillation. You must be prepared to immediately vent the apex of the ventricles with a 16-gauge catheter the exact moment you visualize deadly air emboli traversing the coronary veins.
You must anticipate the destructive blast effect of high-velocity missiles and immediately deploy bioprosthetic adjuncts like Teflon plugets to buttress your Halstead mattress sutures against the friable necrotic myocardium.
And above all, you must respect the crushing systemic physiologic cost of the aortic cross-clamp, knowing that every single second those jaws remain closed, you are marching your patient toward ischemic, multisystem organ failure and the lethal tetrad. The EDT is a precarious bridge, and you must cross it with ruthless, calculated efficiency.
I want to leave you with a final thought to mull over, returning to that fascinating futuristic anomaly tucked away in the text, the Waterworth case report.
Yeah.
We just spent an hour discussing the immense, almost insurmountable difficulty of suturing a fibrillating, tearing, tachycardic heart in the midst of the lethal tetrad.
We talked about how grabbing the heart with a clamp will kill the patient.
And yet, one surgeon reached for an Octopus, the first mechanical cardiac stabilizer, a tool specifically designed for calm, elective, off-pump coronary bypass in a highly sterile, controlled cardiothoracic suite, and used its suction foot blades to achieve immediate mechanical hemostasis and perfect muscular immobility in a crashing, dying trauma patient.
An incredible thought.
Considering this incredible crossover of technology, are we rapidly approaching a future where advanced cross-disciplinary technology from elective surgical suites becomes standard mandated issue on our ED trauma carts? If stabilizing the myocardium mechanically can outright prevent the electrical dysrhythmias that kill our patients on the table, what other elective tools should we be dragging down from the OR to the trauma bay when things get truly critical? Are we limiting our success by relying purely on brute force trauma techniques when elegant cardiothoracic technology exists?
Something to seriously think about before your next code.
Thank you for joining us on this deep dive into the absolute bleeding edge of surgical resuscitation. Stay sharp, trust the evidence, respect the physiology, and we'll see you next time.